Okay, so the next, from now until lunch, you've got basically two things: thyroid, which is quite important because that's a large proportion of patients that are scanned because of thyroid nodules, and then the practical demonstration and practice of performing fine needle aspiration cytology / core biopsy. So thyroid nodules, first of all. So keeping it very simple, what do we want to know when you're ultrasounding some thyroid? Whether the thyroid is normal or not abnormal. If it's abnormal, is it enlarged and or does it have non-nodular abnormalities? The commonest thing is thyroiditis. So patients who have autoimmune thyroid disease, very common, and they will have this sort of coarse ecotexture nature of their thyroid gland. And or does the thyroid have nodules within? And this, I'm concentrating very much on thyroid nodules for the purpose of today. Next slide, thanks. So of a nodule, you might think of it as somebody who has essentially a normal thyroid gland with a single nodule in, a solitary thyroid nodule, and want to do an ultrasound grading of that in a second, and then fine needle aspiration cytology if indicated. Essentially, many people will have many nodules in the thyroid gland. That's not uncommon either, and in essence, you shouldn't really differentiate the two. So, just because there are many thyroid nodules, you shouldn't treat each nodule differently to a solitary thyroid nodule. But common sense applies, and in reality, most people who have multiple thyroid nodules do so because they're all multiple colloid nodules, so they're all benign. But and in that situation, you want to check that all of the nodules that are recognisable, above a size of say 4 or 5 millimeters plus, do look generally benign, and pick out any, if applicable, that don't look benign or look a little bit odd or a little bit dominant. And that's not because they're necessarily bigger than the others, but they may look different from the others because they have a different ultrasound grade. Thank you. So this, in the assessment, there's basically two steps. First is the performance of the ultrasound and grading of the ultrasound nodule, and the second step is performing cytopathology. And put simply, the ultrasound, the purpose of the ultrasound is to determine which nodules need FNAC and which nodules do not need FNAC. And then the management is really directed by the cytopathology, i.e. the Thy classification, rather than the ultrasound classification. So, and there's a bit more to it than that, and you might, people describe using ultrasound alone or in concert with the cytopathology to help risk stratify different thyroid nodules. But put simply, and this is sort of 99% true anyway, is that the purpose of the ultrasound is only to describe the nodule as you see its size and characteristics, and therefore determine whether FNAC is required. And further management is directed on the FNAC, minimally on the ultrasound, except when you get a discrepancy. So something that looks really worrying on ultrasound, but the FNAC actually comes back as, say, benign, thinking, are you happy with that or not? Usually, the cytopathology trumps. Next slide, please. So there's been a little bit of change in thyroid nodule assessment. So what we've had since 2014, the BTA guidance, is the description and popularization of performing of the U classification, ultrasound classification, BTA U classification for thyroid nodules. And essentially you perform an ultrasound scan of the thyroid nodule. If it looks benign, which is U2, and that will be explained by Veena shortly, it's benign, no FNAC is required, end of story. So from the clinician's point of view, from the thyroid surgeon's point of view, you can say, yes, got a benign thyroid nodule, unless it's causing a problem, it can be ignored and discharged. If, however, it looks either indeterminate, U3, or suspicious / worrying, U4 or 5, then clearly an FNAC is required. Or indeed, if the patient has certain risk factors, so that might be a family history or previous ionizing radiation exposure, there is an indication to perform fine needle aspiration cytology. And then, as I said before, the rest of management, next slide, thanks, goes on the thyroid classification. I won't dwell too much on this, but this will be described, but this is the U classification. U1 is normal, by the way, so we're only really dealing with, assuming somebody's got a thyroid nodule, it'll be U2, which is benign, U3, 4 or 5. And there is a graduation in malignancy risk, so U2 should actually be, I don't know where that figure came from, but other papers show much less than 1%. And then going up a little bit for U3, U5 is 81%. In fact, in our figures that we looked at here, they're nearer 100%. Next slide, thanks. And then, as I said, the further management of thyroid nodule is very much determinant on the thyroid pathology. So on the old guidelines, Thy1, non-diagnostic, repeat the FNAC, essentially. You would not normally go straight to diagnostic surgery unless there's a reason, i.e. maybe the nodules causing a problem. Thy2 means that it's benign with a high level of confidence, and essentially patients can be discharged in the main. Thy3A, indeterminate categorization, indeterminate follicular lesion. Patients can have a diagnostic lobectomy, but in the main they should really have just a repeat FNAC, because at least 50% of them on their repeat FNAC will be benign, i.e. Thy2, hence not needing any surgery. Follicular lesion, Thy3F, requires diagnostic lobectomy, because in theory, a proportion of these, in theory, follicular carcinomas or FEPTCs, follicular variant papillary thyroid cancers, will often have a Thy3F classification. And 4 and 5 need surgery. And it's beyond the remit of today to discuss whether, for example, for somebody with a Thy4 categorization, they should go straight to definitive thyroid cancer surgery. Because even on these figures, 25%, 1 in 4, don't have a cancer. In fact, on our figures from MFT, it's a lot more than that don't have cancer with Thy4 classification. Thank you. So how things have changed with the NICE guidance that came out in December. In terms of the initial ultrasound, not much, except that the guidance has gone away slightly from the U classification. So in the draft guidance, before it was finally published, it very much favoured the EU TIRADS classification for thyroid nodules. In the final one, presumably because of some pushback from some stakeholders, it's gone away from that and said, use a ultrasound classification, e.g. BTA U classification, which most of us are familiar with because we've been using it for the last, 8 years or so, or the EU TIRADS. And essentially, EU TIRADS, if it's classification 2 or it's 3 and below 2 centimetres, it's like a U2 nodule. You don't need to do an FNAC. And the others, or if there are patient risk factors, you go on to do an FNAC. So the main change is, great. If you can, next one, thanks, is the description of this. So my recommendation, and really I suppose every department should have a uniform policy, but if you are starting a new ultrasound department or service de novo right now, I would get everybody on the same page and probably familiarising themselves with EU TIRADS and trying to get used to that, because I think it's a better system. It's much more uniform and less subjective and open to interpretation. And it's more in keeping with what the rest of the world use, although the American version of TIRADS or Korean version of Thyroid or whatever. And I'm sure this is the way things are going to go over the next 5 or 10 years. I think this will become the main reporting mechanism, reporting ultrasound classification. Next slide, thanks. And so in terms of how the NICE guidance have changed how we deal with the different cytopathology classifications, there's not a great deal of difference, except there's two things to note. Firstly, there is much more emphasis on core biopsy in thyroid nodules, particularly not so much as an initial investigation, but either as a follow-up investigation or for investigation when the initial cytopathology is either indeterminate, e.g. Thy3A, or non-diagnostic, Thy1. Exactly where this has come from is I don't know. For example, whilst we've got a great, well-established cytopathology Thigh classification, there isn't a histology classification for different nodules. It's just histology. So it hasn't really been worked out, and I don't really understand that practice, because I'm not aware of many people doing FNA-Bs, true cut biopsies for thyroid lesions, unless in exceptional circumstance. But nonetheless, that's somehow cropped up in the NICE guidance. So greater emphasis on doing core biopsies if necessary. And the other thing is before it recommends really all Thy2s, i.e. benign, with high degree of confidence, 0 to 3%, that should be reassessed at 12 months. And that can be another ultrasound, it can be ultrasound with FNA or biopsy, which seems a bit overkill, because that means some patients are going to end up needing surgery, because when you do the needle test again, it's going to come up with something that's not Thy2 for various reasons. And I'm not quite sure where that's come from, but that's in the guidance as well. So I'll hand it over to Veena, who's going to describe the ultrasound characteristics in more detail. Thank you.
So hi everyone, I'm Veena, and I'm one of the head and neck radiologists based at MFT. So I actually work cross-site between Manchester Royal Infirmary and North Manchester, so you may bump into me if you're ever at these sites. So following on from Professor Jared's presentation, we're just going to focus on ultrasound assessment of thyroid nodules. This has been very thoroughly covered in terms of technique by Fiona and Michael. So essentially, we're just going to talk about how to interpret images and get the best out of your evaluation. We're going to chiefly go through the main scoring systems, being the BTA guidelines, which came about in 2014, and more recently, the EU TIRADS guidelines, which has been published in 2017. So next slide. So this graph, and I'm sure you're aware of this already, but this just kind of demonstrates the exponential increase in the detection of thyroid nodules and hence malignancies in cases where this may have been clinically occult in some patients. This is largely due to the increased use of cross-sectional imaging, such as CT and MRI, which detects these incidental nodules. But also, just generally when performing an ultrasound neck, you're highly likely to find an incidental thyroid nodule, and therefore it has become a very large part of head and neck radiology in performing thyroid ultrasound and performing risk stratification based on scoring systems. So next slide. So the key thing that you want from ultrasound, and studies have shown in literature that up to 70% of the general population can incidentally have a thyroid nodule. So the key thing that we want to do with ultrasound, all of these features are important, but the thing we value the most is the high negative predictive value to reassure this inevitably high proportion of patients that a nodule is benign and does not need further investigation. So next slide. This, as you know, reduces unnecessary FNAs, biopsies, as you said, can just cause more problems than they're worth, really, and then in turn reduces unnecessary surgeries, which have their risk factors. So next slide. So this has already been covered, really, by Fiona and Michael, but I'm just going to just quickly whiz through this slide. So I tend to have my patients actually lying flat, although 45 degrees is absolutely fine. I want to make sure the patient is comfortable, so it's completely dependent on their comorbidities and how well they can tolerate this. I like to have the neck hyperextended as well, as it just opens up the field of view and allows you to get better pictures. And it also allows better surface contact with the skin. We use high frequency linear transducers. For the thyroid, I would recommend 8 to 12 megahertz, as it's fairly superficial, but you do want to get a good view of the deeper aspect, the deeper lobes of the thyroid gland. And we measure things in 3 dimensions. We do the transverse plane, where we take an AP and transverse measurement, and then in the longitudinal plane, we will assess the craniocaudal length of the thyroid and any nodules. So next slide. So this is, again, you've seen this already, plenty during your demonstrations. This is just what you would see on a normal axial ultrasound view of the thyroid gland. As you can see, very clearly see the soft tissue and the strap muscles in high resolution, proving that the settings have been optimized. You can see the carotid vessels, which is essential for calibration when assessing Doppler flow within the thyroid and also within nodules themselves individually, which form an important part of the BTA-U classification system. So next slide. This is just summarizing the key features of ultrasound that we use when interpreting thyroid nodules. The most important feature out of all of these has to be the B mode and grayscale for assessing morphology. And this just basically shows the basic composition of a nodule, whether it's solid, cystic, colloid, and calcification, etc. In terms of Doppler, as I mentioned, this can be used in U grading for the BTA classification and also for assessing for pathologies such as thyroiditis. But in this presentation, I'm just going to focus on the nodules. I've mentioned elastography here, but this is actually not something that we use at MFT. I believe the evidence isn't fully out from the ELATION trial, which was a large-scale multi-center randomized controlled trial. So there's not really much evidence to support the use of elastography in assessment yet. But if you were to use it, it would just evaluate the stiffness of a nodule, which a higher stiffness is thought to correlate towards a more malignant feature generally for any part of the body, really. So next slide. And this is just something that you want to include in your reports. It's something that's covered by the U classification system, which I'll show you the charts that we use, and also the EU TIRADS guidelines. The key features to take away from this is that whenever you examine or perform an ultrasound of the thyroid gland, it is important that you do a full lymph node survey from levels 1 to 6, as this is an essential part of evaluating the thyroid gland. And then obviously if you do an FNA or biopsy, you want to record things like the needle gauge, the number of passes, where the nodule is, complications. So these are the key things to mention in your reports. So this is kind of like a study which is an amalgamation of multiple guidelines, being the American College of Radiology guidelines, the American Thyroid Association, and the Korean guidelines. And as you can see, all of these guidelines agree on the sinister signs which are worrying for thyroid nodules, which also have a high sensitivity and specificity. The main things to worry about are microcalcification. As you can see, very high specificity just on its own. Irregular margins is generally a bad sign, really, for any lesion anywhere in the body. Being hyperechoic, darker to the background thyroid gland and strap muscles is extremely worrying. And when you get 2 of these signs combined, the specificity can go up to 95%, so it's a very good predictive value. Just to summarize that, obviously having a scoring system, whichever you use, BTA or EU TIRADS, it's robust. It ensures a good inter-observer variability in terms of interpreting images and structuring your reports. And it just allows effective training and audit so that essentially things are standardized in terms of reporting, knowing when to perform an FNA and interpreting the results and communicating to the patients. So the BTA guidelines came about in 2014, so it's been present for about 8 years now, and it's something that the head and neck radiologists use across MFT. So basically, I'm going to show you pictures. I'm going to show you the chart and pictures of each example, each grading of the thyroid nodules. But it just suggests a basic standard. It recommends when to do an FNA, which basically for any nodule between U3 to U5, FNA is recommended. And it also recommends appropriate follow-up and surveillance based on the morphology appearances on the U grading system. So this is just the ultrasound chart that we use, and it's actually something you'll find in most radiology, in the ultrasound rooms in any radiology department. Some people have varying sort of interpretations about how helpful the pictures are. The main thing to take away from this would be this chart and its descriptions. I would recommend using these descriptive terminologies in all of your reports. And it just helps you justify why you think a nodule is a grade, and it just makes your report more clear and easier to understand. So now I'm just going to show you pictures of each grade. So some of these are my own pictures, but some of these I give credit to Steve Colley. He's kind of like the chief thyroid radiologist amongst the head and neck radiologist, and he has some excellent examples which I put into this presentation. So this is U1, and this is just basically a normal thyroid gland, no nodule. Same applies to EU TIRADS 1. It just applies to a normal thyroid gland, basically. So we've got U2, and you can see that there are a number of patterns that fit into this category. So I'm just going to start off with the top left. So here you've got a nodule that appears partially solid, mainly isoechoic, but the clear feature that points towards its benignity is that it's got this echogenic colloid component within it. So Fiona has demonstrated the colloid comet tail artifact, but you can just about appreciate that with these linear echogenic foci within the nodule. So in the absence of internal vascularity, this would be graded as U2. So to its right, you've got two solid cystic nodules, and it's noted that the solid components within the nodules are isoechoic when compared to the background thyroid gland, which means the same brightness as the thyroid gland. So again, in the absence of any internal vascularity, this would be graded as U2. So now coming to the bottom left, you've got a solid, predominantly isoechoic nodule that has a very well-defined hyperechoic halo just going round. It's continuous. And there are actually some tiny cystic spaces within the nodule that I noted when scanning. There's no internal vascularity within the solid component. So this was something that I graded as U2. And this this causes a lot of debate amongst radiologists actually, but this is a nodule that demonstrates peripheral eggshell calcification. As you can see, this is also present in the U4 category, and therefore it's something that can cause a bit of debate whether classifying it as U2 or U4. The main thing that would put it in the U2 category in this case is that this nodule is very well defined, that calcification is also very curvilinear and well defined, and the solid component of the nodule is confined within that rim of calcification. It does not extend beyond it. And in the absence of internal vascularity, again, this would be U2. So now on to U3, which is generally still considered a low risk, but generally an indeterminate nodule, due to the fact that you can occasionally get follicular lesions, and you can get malignancy within these follicular lesions. So just starting off with the bottom left, you can see that there's a very echogenic nodule. It's markedly hyperechoic compared to this background thyroid gland here. So this automatically would be classed as a follicular lesion. It does have a well-defined halo, and if you were to put the vascularity on with it, you would see some central vascularity. So this is an example of a U3 follicular lesion. Above that, you've got a nodule, and it's very well defined and ovoid. As you can see, you can draw a line around it. It's got a hyperechoic halo, which was noted to be complete and continuous when scanning. In the presence of internal vascularity, this would place it into the U3 category. And then to its right, you've just got a nodule, and you can just about appreciate it's well defined, but there is this echogenic focus which isn't quite on the edge. It doesn't quite look like colloid. I would call this equivocal, and just having equivocal echogenic foci places a nodule into the U3 category. So now we're on to U4, and as you can see, which is actually quite well demonstrated in the pictures of the U staging system, any nodule that is markedly hyperechoic when compared to the background thyroid, parenchyma, and the background strap muscles would automatically just go into the U4 category for being solid and hyperechoic. And then this is just a demonstration on the bottom right of how this nodule has peripheral eggshell calcification, but you can see that there is a solid component of this nodule that's just extending beyond that eggshell rim, and therefore this has been classified as U4. And now we're on to U5, as you mentioned, these are almost definitely malignant, and it's something that I've noted during my audits as well. It has a very high predictive value. So these nodules, to be in this category, anything with a lobulated outline or irregular outline, as all these nodules have, you'll notice that you cannot clearly demarcate the outline of them. Anything with microcalcification goes into U5, which refers to punctate calcification, which is less than a millimetre and demonstrates posterior acoustic shadowing, and just generally in shape being taller rather than wide. And the way we decide this is by measuring its AP dimension compared to its transverse dimension when deciding that this is a taller rather than wide nodule. So all of these automatically place us into U5 category. So as you know, these are the recommendations. We FNA anything that's graded between U3 to U5. U3 is most of the time considered a low risk, but you may get the occasional malignancy present within follicular lesions. So now we're going to move on to the EU TIRADS system. And the pictures that I've used for this part of the presentation are taken from the paper published by Roos et al. As that paper just had excellent examples of what fits into this category. And you'll find that the EU TIRADS uses size as a criteria for FNA, which is obviously not used in the BTA guidelines. So this is just a summary of the descriptive terminology which would fit into each grade. Again, EU TIRADS 1 refers to a normal thyroid gland without any nodules. So EU TIRADS 2 tends to be considered definitely benign, and I'll show you the malignancy risk in the pictures that I demonstrate in the next few slides. EU TIRADS 3 is considered a low risk still, and again, only a set category of nodules fit in here. For EU TIRADS 4, compared to the BTA guidelines, where U4 would be considered a high risk, this is actually still considered an intermediate risk, and therefore this also has a size category for FNA. And EU TIRADS 5, like the BTA U5, means just a very high chance of malignancy generally. So this is a recommendation that the EU TIRADS has come up with for its reporting templates. And as you can see, it's very detailed. It recommends that you state the type of ultrasound equipment you use and probe. It's recommended that you mention all the patient risk factors in your report, being a family history, any past medical or surgical history, and also any previous FNA results. And in terms of the reporting the actual pathology, again, very detailed. So you have to talk about thyroid volume, you have to talk about the echogenicity and vascularity of the gland. But where possible, it's also recommended that you number each nodule and plot these on a thyroid map, which is actually something that's very difficult to incorporate into our electronic systems. But just to let you know, that is actually the recommendation, that you plot out these nodules on the map, and it just allows for accurate comparison. So these are the recommendations of the EU TIRADS. So as EU TIRADS 3 is still considered low risk, the threshold for FNA is about 2 centimetres. And I think they've justified this based on the fact that any follicular lesion less than 2 centimetres generally has a low risk of metastasising elsewhere throughout the body. So generally it's considered a low risk malignancy. if that were to be the case, which is unlikely. EU Thyroids 4, this threshold is lowered to 15 millimeters. Again, this is considered intermediate risk rather than high risk. And then you'll see for EU Thyroids 5, for any nodule that's less than 10 millimeters in size, you can actually consider active surveillance, probably based on the fact that evidence shows that malignancies can be clinically occult for years. However, this is not something I would not consider surveillance unless I had a full discussion with the clinical team, correlated with the patient risk factors, and had a full MDT discussion. But just to make you all aware that this is an option for nodules less than 10 millimeters and with highly suspicious features. So now I'm just, similar to the U grading system, I'm just going to go through these with pictures. So this is EU Thyroids 1. You can see that this is a benign thyroid gland, absolutely no nodule, pristine. So this comes into the 1 category. So for EU Thyroids 2, this is actually probably something that's a bit simpler to understand than the BTA, in that you've got only 2 patterns of nodules that can fit in here. To the left, you've got a purely cystic nodule. You can see that this is just completely anechoic. There's no solid component within it. So this is considered very low risk in Thyroids 2. And to its right, you've got an entirely spongiform nodule. Again, very low risk of malignancy in these. To fit into the entirely spongiform category, it's recommended that the cystic spaces comprise more than 50% of the nodule. So onto EU Thyroids 3, which is still actually considered low risk. You can see this refers to 2 types of nodules. The nodules have to be oval and they have to be well defined with smooth margins. And basically the solid component of the nodule has to be either isoechoic, the same brightness compared to the background thyroid gland, or hyperechoic compared to the background thyroid gland. As I mentioned, the recommendation for FNA is greater than 2 centimeters, based on the argument that distant mets are rarely observed in follicular lesions that are less than 2 centimeters. So onto EU Thyroids 4, which is considered intermediate risk. Again, as you can see, these nodules look far less suspicious than, for example, the BTA U4 category. But these nodules are still oval in shape and well defined. Any mildly hyperechoic nodule would fit into this criteria as well. And FNA is recommended for any of these nodules that are greater than 15 millimeters in size. And now we're on to EU Thyroids 5, and you can see these nodules, they just look very suspicious. So completely ill-defined, spiculated, taller rather than wide. Any of these features automatically puts this into EU Thyroids 5 category. And FNA is recommended only if these nodules are greater than 10 millimeters. However, even if it's less than 10 millimeters, I would have a full discussion with the clinical team before deciding that surveillance is going to be the only option. We don't use vascular Doppler assessment at all in EU Thyroids. This is largely due to the fact that it has been a subject of controversy with the BTA guidelines, in that you'll find that different ultrasound machines just vary in their settings and what constitutes as central vascularity. You'll find that sometimes it's not calibrated appropriately. So generally it's just considered, there's not a good enough evidence base for using it in the EU Thyroids system. And this is just a chart summarizing everything that I've described. So as you can see, there are multiple similarities between the BTA and EU Thyroids grading systems. The main things has to be the morphology of a nodule. They all agree that that's the key feature that you should assess. And obviously worrying things are things that are hyperechoic, solid, any irregular shape or margin, and the presence of microcalcification. The only difference is that EU Thyroids does not use Doppler at all, and also it uses size to guide recommendations for FNA. So I'm just going to very briefly touch upon elastography, although I just must reinforce that it is not something that we use at MFT, and generally it's just not widely used across the UK. But elastography is something that you can use to assess the stiffness of a nodule, and it's thought that a higher stiffness correlates to malignancy. It can do this in 2 ways. You can use strain elastography, where you see how much a nodule deforms when you apply a pressure. and you get some measurements that appear on an elastogram on the ultrasound machine if it has this capability. You've also got the option of shear wave elastography, and this basically just shows the velocity of an ultrasound pulse through a nodule and also displays this on an elastogram. However, the number one assessment has to be the morphology and grayscale features of a nodule, and I would only suggest using this if it is going to be used at all as a purely ancillary feature to help prove that a nodule that you suspect is benign is definitely benign. And this is just a summary showing that there was an elation trial looking at the use of elastography. However, there's no clear outcomes or recommendations yet. I believe we are still awaiting that, but just to make you aware that this was a study that was conducted across the UK. So the final slide on elastography, but there's just multiple limitations. For example, large nodules greater than 3 centimeters, the presence of macrocalcification in any nodule can also limit the interpretation. Any pure cystic nodule, any coalescent nodule, and any nodule in a deep location. So already you can see there are multiple limitations to elastography. So just to summarise, ultrasound is just the gold standard for assessing thyroid nodules, and the use of scoring systems is essential for risk stratification and having a robust training, performance and audit in place. So thanks for listening. Any questions at all?
For want of a better word, it's about bright speckly bits. So if you're differentiating between colloid and microcalcifications, the difference is just whether it's got a black tail or a white tail?
I guess so, yeah. I guess with colloid, you just, as Fiona mentioned, you just see this reverberation artifact going either side, in that it kind of just tails off in brightness and sort of amplitude and thickness towards each end of that echogenic focus. With microcalcification, the presence of acoustic shadowing is not always present, but anything that appears very punctate and echogenic, I would be concerned, and I would definitely do an FNA of it. I think when I see definite acoustic shadowing is when I call it definite microcalcification, but anything where I don't see comet tail or acoustic shadowing, I would call this equivocal echogenic foci, and it is actually something that's debated a lot amongst radiologists. We often get second opinions amongst ourselves, but yeah, they can be tricky, definitely. So, yeah.
What's the smallest nodule you would have a go at via FNA?
So probably 4 millimeters is the smallest that I've done, because we widely use the U classification at MFT, and I would definitely have a go. It may not come back adequate, but I'd say anything below that would be tricky, but it is worth a try, like really. So. That's
when you would be doing sort of interval scans possibly?
Yeah, I would. So what I'd do is, I'd say it's too small. I would suggest discussion with myself, and I would recommend surveillance. But I hope the clinician would also contact me directly, which is really good with our EPR systems. We've got things like secure chat where we can have an ongoing discussion about the patient. So, yeah, no problem.